In Laboratory 6, we're going to go through the ligaments of the lower body, specifically the hip, the pelvis, the knee and the ankle. Remembering that ligaments play a role in stabilizing joints and restricting movements. So those four areas we're going to touch on. We're going to have a look at the individual bones around those to get more in touch with our bony landmarks, and then we'll follow that up with introducing the ligaments as we have done in the previous laboratory.
Okay, so here we're looking at a coxal bone. Coxal bone is an irregular bone. I'm looking at the front of the right coxal bone. I know it's the right because if I rotate this way, I can see this round acetabulum, which I know must be on the lateral side. Here I've got my ischium, which I know is on the back. It's this rounded area where we would sit, like that. And then on the front, I've got the pubis, which is this pointed area. So it's the front because this is the front here with the pubis. The round is on the back, and the lateral side here must be where the leg's coming in with the socket. Therefore, I'm the front of the right. A couple of landmarks just to extend our knowledge. So we already have the three bony regions. This top part is called the ilium, this whole top part here. This entire section at the back here is called the ischium, and this entire section at the front here is called the pubis. So ilium, ischium and pubis. Now, another couple of landmarks that we'll use and use also for the pelvic ligaments coming up. We've got the ischial tuberosity and then the ischial spine, which is this sort of process sticking out here. So ischial tuberosity we've touched on before, and the ischial spine is a new one there we're learning. So the ligaments of the hip, which are all the ones connecting the coxal bone to a femur. So our femur would go in right here. The ligaments of the hip are the ones involving the femur. And the three names of the ligaments come from the three regions of a coxal bone. So the three names would be of the coxal bone was the ilium, ischium and pubis. The name of these three ligaments are the iliofemoral, the ischiofemoral and the pubofemoral. So iliofemoral, that's the iliac or ilium region to the femur. Ischiofemoral being the ischium to the femur, and the pubofemoral being the pubis to the femur. So when we have a look at a model of this, we get a closer look at what these ligaments look like. So this one here that's going up to the top, and we notice it's a split ligament, so it's a V shape coming down. That would be our iliofemoral. So it's actually splitting into two. They're both the iliofemoral when you look at it from the top. Easy enough to spot because it's the only ones protruding up towards the ilium region. When I look at this one down here on the front, it's not going right to the end of the pubis, but it's attaching just to where the pubic region starts. So this would be the pubofemoral. It's the front one, down a bit lower. And then if I flipped over to the back, again, it's not touching right just on the tip of the ischium, but it's touching where the ischium region starts. The only one on the back that's really visible here is the ischiofemoral, right? And it also is the one that if you tract it, it actually spirals inside around the hip. So to cover that again, iliofemoral splitting like a V down from the top, the ilium region. The pubofemoral, the only one on the front, sort of underneath the iliofemoral, and then the only one on the back is the ischiofemoral, which also spirals around. You'll notice they're all on this angle, and that angle plays a role in stability. So if we were to talk about stability of this joint, you would say that these ligaments help to screw that angle, screws in the actual femur into that socket of the acetabulum, making it even more stable. But already this is quite stable. If I talk specifically about, in order of importance, what contributes to the factors of stability of the hip joint, I would actually say the articulating bones is number one, because that nice deep socket creates such a big cavity for this head of the femur to sit nicely into. So head of the bones, the articulating bones coming together is definitely the most important factor of stability, but then those ligaments on that spiral angle, which is screwing into the head of the femur, just makes it even more stable. So the hip's quite a stable joint. Third place would be the muscles and tendons that cover this. We've got a lot of bulky muscles around the hip region, so that definitely is a factor. Number 4 would be atmospheric pressure. So atmospheric pressure of this one is actually quite solid. That deep socket really adds a lot of atmospheric pressure. In fact, if you were to chop away all the muscles and ligaments and just let this leg hang, the atmospheric pressure would be enough to actually hold the head of the femur inside this acetabulum alone. And then skin and fibrous connective tissue, always a factor, just adding a little bit of stability to this joint.
So when talking about ligaments of the pelvis, they sometimes get confused with those ligaments of the hip that we just learned. So the difference with the ligaments of the pelvis, these are the ones involving holding the two coxal bones and the sacrum all together in some way. So there's three we have to learn about here. The first is the iliolumbar, getting its name from the ilium region connecting to the lowest lumbar vertebrae. So the main role of this, which is connecting both of these coxal bones in, is to really hold those coxal bones together. So essentially your pelvis being that bowl of bones with the two coxal bones, the sacrum and coccyx, it's going to hold those all in together, keeping it nice and tight and stable. You've got the sacrospinous and the sacrotuberous. The names coming from two regions of the coxal bone that we just learnt earlier. So sacrospinous coming from the ischial spine and the sacrotuberous coming from the ischial tuberosity. So it's connecting our sacrum with the spine and the tuberosity of the ischium. So the two roles of these, if we think of this as essentially the bottom of our sacrum, without these ligaments, it would have a tendency to wing out. A lot of ways you could say this. So either one, winging out, think of it like a tail. Number two, you could say that's preventing like posterior tilt. So where the iliolumbar held the pelvis together, the sacrospinous and the sacrotuberous prevent that posterior tilt or winging of the sacrum, holding our tailbone like under our body, keeping it nice and vertical. This is another one of those ligaments that we don't, these three of these ligaments that we don't have a model for. So we look at them on the screen, we have to know the names of them, where they're coming from, and what the roles are, but they're not presented with an actual model where you see the actual ligaments. So just don't forget about them, like they're equally as important as all the others. We'll have a look at the roles or the purpose of the patella. So there's four different roles of the patella. Remember, the patella is the sesamoid bone, which means it fits inside a tendon. So it protects the knee joint anteriorly, it increases the leverage of the thigh muscles, it works as a shock absorber and disperses force, and it also decreases friction. Now it's probably easier to see in a diagram of how these all fit together. So we'll now draw a diagram together in our books and show you how these four roles occur as a result of it being a sesamoid bone.
So here we're looking at the knee, and we can see the patella, which is a sesamoid bone sitting inside this tendon. This tendon can be referred to as the quadriceps tendon, also can be referred to as the patella tendon, both acceptable. And it forms a little plane joint, so it's this little smooth surface here on the front, connecting to that front of the femur. And it sits in a little groove and glides back and forth. And that's going to become important when we start talking about the roles of this. So let's draw a picture of the roles. So we'll start by drawing our, it's representing the femur, the upper part of the leg. We'll draw the, say, the tibia, which is the lower part of the leg, and the foot, something like that. All right, so upper leg, lower leg, foot, and we've got our patella, which is sitting not quite in the middle of the space, slightly higher to this femur side, and it's sitting inside the quadriceps tendon. So we'll draw these my quad muscles running down the side of our leg, and it's sitting inside that tendon, which connects just onto the top of the tibia at the tibial tuberosity. So if I were drawing a picture of the roles, the first role we had was anterior protection. Basically, you can see it's going to protect anteriorly everything that's going on inside the knee. If we look at what that actually is going on, we've got a lot of things going on inside this knee. We've got the anterior cruciate ligament, the posterior cruciate ligament there. We've got this substance here, which is called the meniscus, which is the shock absorption component of the fibrocartilage here, creating the shock absorption. This patella is protecting everything going inside here. So anterior protection, very important. And we see if we were to kneel down, we'll notice the patella sort of glides down more into the middle of that compartment. Second is the leverage of the thigh muscles. So the way this works, much like a seesaw, the patella forms a bit of a fulcrum to increase this angle of pull. So in other words, because it's a bit of a fulcrum, much like a seesaw, the quadriceps have more force to lift the lower leg if it was, say, moving into extension. So it helps the leverage of the quadricep muscles. Now the final two roles relate to the fact that this is a little gliding plane joint. So the patella sits here on the surface of the femur and it glides back and forth. So when we flex and extend, it's gliding both in that sagittal plane, but there's also some gliding taking place in that frontal or coronal plane. So the next role is involved with that gliding plane joint, and as we move, it helps to shock absorb and dissipate force. So imagine the quadriceps running down and all connecting in this one area. There's going to be a lot of stress on this tibial tuberosity. That frictionless movement of the gliding plane joint helps to shock absorb and dissipate force. And the final is just straight up reducing friction. Imagine if that gliding plane joint wasn't there and it was just this tendon, like, you know, rubbing on all these parts of the knee without a nice gliding plane force. There'd be a hell of a lot of friction taking place at the knee joint. So reducing friction is the fourth. So just to recap, you've got anterior protection, you've got the leverage that this fulcrum allows, so coming off to increase the force of the quadricep muscles. You've got shock absorption and dissipating force, and then also reducing friction, all related to the fact that that's a gliding plane joint.
So now when we look at the knee, there's 6 main ligaments of the knee. And these were presented a little bit in the lecture, and we're going to talk about them a little bit more now in this laboratory. So we've got the fibula and tibia collateral ligaments. Collateral meaning side ligaments. So one is on the fibula side and one is on the tibia side. We've got the oblique popliteal and the accruate popliteal. The two popliteals are on the back of the knee. So 2 on the side and 2 on the back. These are called extracapsular ligaments, which means they occur outside the capsule of the synovial joint. So we'll have a look at that in a moment. Inside, intracapsular ligaments, that means inside that synovial joint, we've got the anterior cruciate ligament and the posterior cruciate ligament. So remembering anterior being at the front, so there's a cruciate ligament that travels towards the front, and the posterior cruciate ligament is at the back. So these are the full names of the ligaments. Remember, you might have heard, like someone use an anterior cruciate ligament, you might have heard the term ACL or PCL before. We are not allowed to use abbreviations for any of this. We do see a lot of situations where people are doing assessments and you say, what's the name of this ligament? And they'll throw in an ACL. And if you actually ask them what does it mean, they actually have no idea. So full names for all of these ligaments are critical, particularly these ones where people do have a tendency to shorten down. The fibular collateral ligament can also be referred to as the lateral collateral ligament, and the tibia collateral ligament can also be referred to as the medial collateral ligament. Those names are used interchangeably. Take a moment now to write these in your book if you haven't already. Now if we have a look at the anterior picture of the knee, and I've drawn a red circle around to represent where that synovial capsule would roughly be. The words here are really small, don't worry too much about reading, but you get the idea by looking at the screen. So the fibular collateral ligament would be the ligament, collateral meaning side again, from the fibula connecting up to the femur. Right? So it's on the fibula side connecting up to the femur. The tibia collateral would be on the tibia side connecting up to the femur. Notice they're both outside that synovial joint, which means they're extracapsular on the outside. We see when we look at the inside, you've got the anterior cruciate ligament and the posterior cruciate ligament. Difference here being they actually both start at the back. The anterior travels forward and the posterior stays at the back. So from this view, we see 2 extracapsular ligaments and we see the 2 intracapsular ligaments. In order to capture those 2 popliteal ligaments, we'd have to look at this in a posterior view. So this is behind the knee, and we see a lot of ligaments crossing all over, helping to stabilise this knee joint, which is otherwise pretty unstable. Across the back, you've got the oblique popliteal ligament, so represented here by this blue square. Oblique, it's running on an angle, popliteal being behind, and you've also got the the accruate popliteal ligament, going from the head of the fibula up into that synovial joint. So these are both extra capsule ligaments. As a matter of fact, they form part of that capsule. So now we're going to have a closer look at the model, and we'll look at some of those bony landmarks we mentioned and where the actual ligaments are connecting to and from, and we'll talk about the individual roles of these ligaments.
So when we look at this model, there's actually 3 joints presented in this model. We've got number 1, we've got this patella onto the femur, which is that gliding plane joint. That's the patellofemoral joint. You've got the tibia on the femur, which is the tibiofemoral, which is the bicondyloid joint. So we see the 2 condyles of the femur creating that bicondyloid joint. So that was the bicondyloid, that was the plane. And then we also see in this model where the fibula meets the tibia, that is the proximal tibiofibular joint, which is also a gliding plane joint. So when we look at this model, first we identify which one's the tibia and which one's the fibula in the lower leg. So the tibia is the much larger bone in the lower leg, with the fibula being here next to it. We've got the 2 collateral ligaments on the side. The one on the tibia side is called the tibiocollateral ligament, also referred to as the medial collateral ligament. The one on the lateral side is the fibulocollateral ligament, also referred to as the lateral collateral ligament. The 2 extracapsular ligaments actually aren't visible on this. As I mentioned before, they form part of the joint capsule. So they're not visible on the model because the joint capsules have been taken off. You would have the oblique popliteal ligament running sort of diagonally across the back of the leg, and the accruate popliteal ligament connecting the head of the fibula up into that joint capsule. Inside, we've got the vision of the 2 cruciate ligaments. Notice they both start at the back, but it's this one that comes forward, the much thinner one. That is the anterior cruciate ligament, so starting at the back, coming forward. And on the back, splitting into 2, is actually the posterior cruciate ligament. So if I talk a little bit more about the roles now of these ligaments, the 2 collateral ligaments are really just limiting that movement from medial and lateral, so stabilizing the joint. We already don't abduct and adduct our knee, so it's more about stability than about actual big movement going on here, because we don't move in that way anyway. So the 2 collateral ligaments limiting medial and lateral movements. On the back, the oblique popliteal ligament is going to play a role in limiting hyperextension. So think about it, if I hyperextend my knee, that's the oblique popliteal ligament that's going to come into play there. The accruate popliteal ligament plays a role in connecting the head of the fibula just with the joint capsule. So think about this separate bone just being held into the tibia. And then we've got the 2 anterior and posterior cruciate ligaments on the inside. And what they actually do, it's probably easier to describe using a bone. Right, so here I'm looking at the front of my right, this is my femur, this is my tibia. What it actually does is the anterior ligament prevents what we call anterior displacement of the tibia. So that movement right there, so the tibia drawing forward, right? And one way, like a lot of people have hurt the anterior cruciate ligament, what they tend to do is they deaccelerate, and when you deaccelerate, just try this at home if you just kind of, go to do a sidestep in some way. Deaccelerating actually opens up this space, so the anterior movement of the tibia comes forward, and then if you change direction, you actually sort of screw the anterior cruciate ligament, you kind of shear it straight off. So that forward movement with turning, right, such as what happens when we deaccelerate and change direction, puts that anterior cruciate ligament in a real vulnerable position. Now the posterior cruciate ligament prevents posterior displacement of the tibia, so the tibia drawing backwards. This movement's nowhere near as common because we don't hyperextend our knee that much. It can still happen. It happens if you, say, move in, like step in a divot, or you're perhaps running backwards, or just get a bad angle, so it can be injured. But it's less likely that your tibia tracks backwards on your femur, so it's less injured than the anterior cruciate ligament. It's also a much thicker ligament, that posterior cruciate ligament, so it's a little bit stronger than the anterior as well. When we're looking at the factors that contribute to the stability of the knee, we must think about how these bones are coming together. So the fact that they're not really deep sockets means the bones are doing very little in comparison to other joints. So we see here the tibia right there. They're the 2 spots where those femoral condyles come down in. They are very, very shallow. It's almost a borderline gliding plane joint. So it doesn't receive a lot of stability from the articulating bone. So that's definitely not first on our list. The ligaments would be first on the list. There's a lot of ligament action going on with our 6 ligaments in total, really contributing to the stability of the knee joint. And whenever ligaments are first and not bones, it's not as stable. So you would say that the knee compared to the hip is much less stable. So ligaments, number 1. You've got the muscles and muscle tendons crossing the knee, which is number 2. And then our shape of our bones dropping right down. Atmospheric pressure is not great either, because you've got not this deep connection between these 2 bones, and as always you've got the skin and fibrous connective tissue. There's one extra one for the knee because it's got this bit of fibrocartilage in here, which we call the meniscus, which not only plays a role in absorbing shock between these 2 bones, but as you can see when you look inside it, it creates these nice deep grooves. If anything, you would say that deepens the socket. So the meniscus not only plays a role in the shock absorption, but also creates a collar, if you like, for the femur to sit a little bit more snugly into this tibia. So it definitely plays a role in the stability of the knee also.
So when we look at ligaments of the ankle, we see models like this. There's ligaments all over it. It can be very confusing as to which one's going where. But there really is only 4 main ligaments of the ankle that we have to learn. There's one on the inside, as this is looking at the inside of the leg, and 3 on the outside. We'll have a closer look in a moment using the model, but just for starters, we've got this one on the inside called the medial deltoid ligament. Medial or deltoid, really those names are interchangeable. Gets the name deltoid, I've just highlighted this symbol, it's triangular shaped ligament. So a lot of people think of the deltoid, they think of the shoulder. The shoulder is this muscle here on the shoulder is called the deltoid. That's because it's a triangular shaped muscle that travels from a broad origin down to a narrow insertion. Very similar to this is covering a lot of ground here in the tarsal bones, but then connecting up to a more refined point. So the name deltoid ligament is used to describe the shape. That's quite strong, it's quite stable. We rarely in comparison have injuries to the medial deltoid ligament. In comparison to these 3 little ligaments of the lateral side of the ankle. So these 3 little ligaments, we'll go through the names and the description of these in more detail in a moment, but they're really quite unstable. They're really subject to injury. One, because of the way we move, there's more of a tendency to roll our ankles out or put us into excessive inversion, but also because they're really small and really weak. So a lot of injuries typically occur in these ankle ligaments. Specifically, these injuries are occurring from front to back. So when we roll an ankle, we typically would injure this one, anterior talofibular ligament, then the calcaneofibular ligament, then the posterior talofibular ligament. But to get the words and the naming of that, we'll have a closer look at these on the model and using our bony landmarks for progressing.
So when we're looking at the ligaments of the ankle, we must just revise a little bit of these bones so we know what's what. So remember, the calcaneus is the big heel bone here, which you see in the most from the top and the most posterior bone. The talus sits here on top. The navicular sits here in front, and they're really the only ones we need for the actual ankle ligaments. So calcaneus, talus, navicular. Because when we bring in the ankle, so I'm looking at the top, the front. So here, if I'm flipping it to the inside, again, you've got a lot of things going on here, which most of these here, like this here is a muscle tendon, because again, they sort of goes like it's going indefinitely on. But this in here underneath it, this one that's coming down from the tibia and touching the navicular and the talus, sort of making that sort of triangular shape, that is the medial deltoid ligament. So all this other stuff we can ignore for this purpose, but we know where the medial deltoid ligament is. It's coming down and fanning out in that triangular shape fashion. So when we flip around here to the lateral side of the foot, the outside of the foot, we've got the 3 lateral ligaments here. Now, it gets a bit confusing because there's a lot going on here, but if we look at where the talus is, that's that bone on top. We look at where the fibula is, we look at where the calcaneus is, right? We can determine, and there's my ankle joint there, occurring between the tibia and the talus, right? So there is only one on the front, so the anterior talofibula. From the talus to the fibula on the front, it can only be that. This one here is too high, it's not even touching the talus, and there's nothing else that goes from the talus to the fibula. So that one there is the anterior talofibular ligament. Again, if we look, find the calcaneus, there's the fibula. There is only one ligament that goes from the calcaneus to the fibula. It's this one right here. That is called the calcaneofibular ligament. So when I look at the back, you can see from the fibula to the talus, this one dropping down, not the one staying up touching the tibia, that is the posterior talofibular ligament. So we had the anterior talofibula, talus to fibula, the calcaneofibula from the calcaneus to the fibula, and then the posterior talofibular ligament. Now, interestingly, these ligaments play important roles. And one of the main things they do, the lateral ones, limit that inversion. So if my foot inverts in, so the sole of my foot faces inwards, it's these lateral ligaments that come under stress. And they also come under stress from front to back. So when you actually sprain your ankle, it kind of goes like that. And the ligament here at the front goes first, usually under the most pressure, then the next one, then the next one. They're injured in order from front to back. The deltoid ligament on this side is much bigger, much thicker. It prevents eversion, which is a less common movement, and also the strength of it is much less commonly injured. So the lateral ligaments limiting mainly inversion, the medial ligament limiting mainly eversion.
So now we're going to have a look at the arches of the foot, and there's three arches of the foot that we need to learn. First is the medial longitudinal arch, then we've got the lateral longitudinal arch, and then the transverse arch. So there's a lot of information here, and this is actually written in the shortest space possible. So the medial longitudinal arch connects calcaneus to talus and metatarsals 1, 2, and 3. And we use this language like talus is the keystone to this arch. And I'll describe what a keystone is in more detail using a picture. The lateral longitudinal arch goes from the calcaneus to the cuboid, metatarsals 4 and 5, with the cuboid being the keystone for this arch. And then the transverse arch crosses the junction between tarsals and metatarsals, and there's no keystone for this arch. Let's have a closer look at those in our book.
All right, so when we're talking about the arches, let's first recreate a picture of our foot. So looking at it from the superior view, we draw something like that looks like this. Something like that. All right, so I just drew the metatarsals on there, 1 through 5, and our phalanges would be protruding beyond that. When we look at our 7 tarsal bones, I've got the calcaneus, the talus, the navicular, the cuboid, and then my 3 cuneiform bones, my medial cuneiform, my intermediate cuneiform, and my lateral cuneiform. Now, you guys should all by now have a really good grasp of where these bones are and be able to draw them in order and name them by now. So when we talk about the arches, we've talked about these keystones. And when we said keystone, we're referring to the top of an arch. So to put that in perspective, if I were to draw like a little archway, it's like something like this. Little archway, and let's say we stood underneath the archway. This bone on top, or this part of the arch, would be referred to as the keystone. Right, so the top or the high point of an arch. So we help to use that when we're talking about these bones. So we've got the medial longitudinal arch, which starts at the calcaneus. It rises up to the talus, which we've said is the keystone, and then descends to metatarsals 1, 2, and 3. So it runs the whole length of the foot, going from the calcaneus, rising up to the talus, and then descending to 1, 2, and 3 metatarsals. With the lateral longitudinal arch, it starts at the calcaneus as well, but it rises up to the cuboid as the keystone, and then descends to metatarsals 4 and 5. All right, so notice the cuboid, it's actually a lower bone than the talus. We'll look at that in a moment, but it's further in front than the talus. All right, and then we've got the transverse arch. And there's no keystone talk with the transverse arch, but it crosses the juncture between the tarsals and the metatarsals. So in other words, when we look at a foot, it's a 3D object. You've got the arch on this side of the foot, which is quite steep. So you notice this is the medial longitudinal arch. The arch on this side of the foot, it's still there, but it's much, much lower. That's the lateral longitudinal arch. And being this 3D object, the arch which runs across the foot like that is the transverse arch. If I were to draw this, let's just draw a cross-section view of what this might look like. So the medial longitudinal arch, if it say started here, this is my calcaneus, it's representative. Let's say it rises up quite steeply to the talus and then descends to 1, 2, and 3 metatarsals. If I drew the lateral longitudinal arch, I would say it also starts at the cuboid. It rises up to, sorry, it starts at the calcaneus, rises up to the cuboid, and then descends to the 4th and 5th. So the arch on the lateral side is much lower, with the high point being further forward than the medial longitudinal arch. So when we look at the arch, I wonder what it's for. Like, why have an arch at all? Well, if I put some pressure down on the arch, just think about this is us under load. The arch actually operates like a spring. So when I push down on my arch, just like you stepping on the ground, the arch flattens and then it lets off as well. And that's allowed by both the arches and the many bones that make up the foot and the joints between them, which are for the large part gliding plane joints. So in order to think about this, the best way we can do is draw a little picture to describe what the arches do. So if this represents, say, my foot, a little bit of a squash foot, it's all right. So toenail here, just to give it some perspective. Here's my floor. The arch works like a spring. So the two main roles of the arch are to shock absorb. So think about when that spring compresses, that's the load of our body coming down. Shock absorption. But then when the spring's released, it also helps propel us forward, so propulsion. So think about the spring collapsing, absorbing the load, and then helping propel us forward. That's what that arch is for. Now, when we look at the maintenance of the arch, we think about how is this maintained? What's going on here? If you think about the arch, really it's just a series of joints. When you think about the foot is made up of these 7 tarsal bones, then into the 5 metatarsals. It's a whole lot of small bones here. These are short bones, these are long bones, but all of them are quite small. That helps us adapt to all kinds of uneven terrain, but the actual arches are maintained much like a joint is maintained. Being gliding plane joints, the bones coming together here don't actually play a big role. The number one role is all these ligaments and tendons and everything running across this bone. So ligaments first, then the muscles help to maintain these arches, help to hold it in place, and then finally the shape of the articulating surfaces. The gliding plane joints allowing the gliding action means those bones don't really lock in, which means they're sort of freely glidable. The bones are not really supplying much in the way of maintenance of the arches. So ligaments first, muscle and tendons crossing over this area second, and then the shape of the articulating surfaces last.
So at the completion of Laboratory 6, the ligaments of the lower body, we've learned about the ligaments of the hip, the pelvis, the knee and the ankle. And we've also talked about the arches of the ankle, not just what they're called, but where they're going from and to and what the keystones are. The final thing in this lab is a bony landmarks page. Now, some of these landmarks we've already done, and we've seen some of them just recently in these weeks. There's also some on there that we don't know yet. But all these landmarks works like a checklist. They're going to be used in future weeks when we start talking about muscle origin insertions. So the idea of this page is to use it like a checklist, to go through it and make sure you know them all. Now, you won't get this necessarily in one go. It might take several weeks to learn. But the sooner we learn these landmarks, the better we are when we start doing muscles origin insertions, which can become quite difficult. So have a look at the bony landmarks page, use it like a checklist. Tick off the ones that you already know, and then have a look and look up the ones you don't know. And in the coming weeks, we'll also touch on those ones that we haven't covered yet. So at the completion of the next series of labs, we'll know them all.